Hello and welcome to Talking Meds, a podcast from PrescQIPP, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill, Medicine's Clinical Advisor here at PrescQIPP. Hello and welcome to this episode of Talking Meds, where we're going to be talking about taking medicines during periods of fasting. This is particularly relevant at times of the year like this during Ramadan or during Lent for some Christians who observe that. And of course, intermittent fasting is very popular as a way of losing or maintaining weight. To discuss this, I'm joined by Dr Salman Waqar. Salman is a GP with a background in academia, policy, medical leadership, public health and education and training. He also has a strong background in community organising and advocacy. He has vast experience of teaching and training for organisations such as the Royal College of GPs and the Royal Pharmaceutical Society, and has an honorary academic position at Imperial College London, having published over 40 peer-reviewed papers and book chapters. We'll put a link in the show notes so you can get a list of those should you wish to have a look. We've been keen to do an episode on medicines issues during periods of fasting. And I was talking to Sundus Jawad about this, about whether she had any ideas for guests, and she recommended you, Salman. So there's no higher honour than that, as far as I'm concerned, because Sundus is an absolute megastar of the pharmacy world. So thank you very much for joining us, Salman. How are you doing?
Yeah, I'm very well, thank you. It's a great honour to be here. Thanks for having me.
Absolutely. So just tell us a little bit about your background and your current role and why the interest in this topic.
So I'm a GP, and as most GPs, sort of jack of all trades and master of none, like to dip my toes in many different things. So I've always felt that experience was the currency of life. So I've been picking up lots of different things in my career, a bit of academia, a bit of policy work, and a few other things that you mentioned. So I've had really good fun doing that. I'm a portfolio GP now, and that's where I go about my working week. But this issue actually that you're talking about here, it was actually a very serendipitous or a fated moment, however you wish to look at it, in that I just not long finished my GP training as a academic clinical fellow, and the pandemic had begun in 2020, if you remember, and there was a big concern at the time around people who wanted to fast in Ramadan. Is that safe to do? Because we were doing all things differently. We were socially interacting and all the other things that were there. And so my master's was in evidence-based medicine. It was at Oxford, and I'd gotten to know quite a few, of other academics in that journey as well. And I was actually looking at my thesis at the time was looking at faith organizations and their role in cancer screening and cancer detection. And that was actually based on my previous, you mentioned a few other things I did. I was at the time, and still am, involved in the British Islamic Medical Association, which is an organization of Muslim health professionals. And having had the academic training and having had those networks and having had all that exposure, this was the perfect sort of time to look at this issue. Who can and cannot fast? Based on medical grounds, what does the evidence say about those issues? Because prior to the pandemic, it was a very common thing to be asked about whether someone should or shouldn't fast. And often it was all about through the lens of diabetes. And it was rather unfulfilling to not be able to give someone an answer. And the urgency of the pandemic really allowed us to sort of bring all of that home. So yeah, all of those experiences really came home to roost in that moment. And, we pulled together. I think as we all did, we just tapped into some reserve that we didn't know we had. Maybe because we weren't sort of having to commute to work for the first time in a very long time, who knows? But we got about 120 academics together in a very short period of time and did a real rapid review of the evidence. And that's essentially what led to the work that we've got now.
Yeah, it is interesting, isn't it? How sometimes either serendipity or force majeure brings out these circumstances. Some of the research that's been generated through COVID, for example, is fascinating in terms of the impact that had on the research community. So, I mean, we'll come on to maybe the guidance and evidence for this later on, but what are the particular challenges when taking medicines during periods of fasting?
So there's the individual themselves, the patient, and the context that they're in, for starters. So I've often seen, in fact, data supports this, that of all the rituals that are there within the Islamic faith, the ritual of fasting, which to be clear also includes not having any water, and it also includes not having any medication through most um, routes. I mean, transdermal routes and other routes most will allow that, but the majority of our medication is taken orally. It doesn't allow for that to happen. You've got people who are incredibly motivated to fast in this month, and this includes people in developed and developing context. Because typically we see in other sociological data that more affluent and more secular communities may not be so practicing of certain religious traditions, and you see some of that in the data around the observance of prayer, for example, in the Muslim tradition. But the fast, on the other hand, is one that consistently, regardless of where people are, whether in the West or in the East, whether they're rich, whether they're poor, they observe that. So there's a very strong innate motivation for people to fast. There are reasons for that, probably the social aspect of it, in terms of people being part of that whole month of and the anticipation that comes with it. But there's a very strong desire for people to fast. So that does bring a set of challenges that you have to bear that in mind, is that you can have some very frail um, people on a significant number of medications being quite poorly, yet still somehow saying that I managed to fast in the past. And how do you square that with sort of the evidence that we have, good clinical practice that we know of, the guidelines that we have, and the increasingly fraught world that we operate in, where there's a lot of complaints and negligence and patient safety issues and so on. And then there's also the context of around those communities that people are in. This what can sometimes be falsely perceived as people not being able to undertake Ramadan properly if they're not able to fast. And that's not so much. It is also affecting the individual, but it's also how the community perceives that person, or the person that's advising someone not to fast, as someone who may be not in the spirit of the community, or not aligned to the patient's needs, whereas actually it is something that is very much supported by Islamic traditions about not fasting if fasting is going to cause you harm. So it's both the individual and the context that they're in do provide quite some interesting challenges. And of course, how do we advise people? What evidence that we using? What weight do we put on that evidence? And how do we avoid eminence-based medicine, which is what we often see, as opposed to evidence-based practice, noting that a lot of that evidence is actually rooted in context outside of Western developed countries, and often in hot, dry climates, as opposed to wet and cloudy skies that we experience.
Yeah, so I mean, in preparation for this, that some of the things I read is about 93% of Muslims will observe fasting during Ramadan. Um, and obviously that, as you say, that's actually quite a high proportion. And therefore, there are going to be some people who have got chronic conditions where taking medicines is really important to their ability to live their lives in a normal way, so they can function in a normal way. And as you say, you often think about this with things like diabetes, obviously, because food is really important to the regulation of diabetes. But there's also things like if you've got an acute illness, say you've got a urinary tract infection or something like that, and you've got significant pain associated with that urinary tract infection, what do you do during Ramadan? And I think it's also, again, correct me if I'm wrong here, Salman, this is my sort of lay understanding of this, but the fasting takes place during daylight hours, doesn't it? So you can take food and tablets, etc., during the nighttime hours. Is that's right, isn't it?
Yeah, yeah, absolutely. So it is from pre-dawn, so it's not the actual dawn that you sort of see in the movies where the sun is coming up the horizon. It's before then. So the first whiteness that exists in the sky, and that's usually about an hour and a half or so before the dawn that we see where the daylight breaks, all the way until sunset. So in the UK, as you know, in the winter months, that's quite short. We have very short days, as we all like to complain about. But in the summer, they can be quite long. Yes, when the sun has set in the evenings, then that's where people start drinking. That's when people start eating, and that's when people start taking their medicines as well.
So I think practically, if you're taking your medicine once a day, that's something you can potentially cope with fairly easily, or even twice a day. You can cope with it quite easy. But if your medicine regimen is 4 times a day, that's when it becomes potentially more difficult, isn't it?
It is, yes. I mean, it's not just purely the frequency of the medicine. There are going to be some medicines that are going to be very sensitive to, how you're taking them, and what else you're taking them into. For instance, lithium, for people with as a mood stabilizer, you need to ensure that your hydration, you're adequately hydrated. If you're looking at, again, in mental health, you're looking at some of the antipsychotics, then they can be quite constipating. And if you're not drinking throughout the day, that can worsen your constipation. You've also got some medicines where it's not quite so straightforward as just, clumping it together, or just, if it's a case of a BD dose, you just sort of say, well, if it's a 14-hour fast, it doesn't matter if you miss a few hours here and there. If you're someone that's taking a if you're on antiplatelet therapy and you're on having the timing of that right is quite important, and can be quite important. In Parkinson's, for example, timing is incredibly important. So yeah, so the timing of the dose is certainly one aspect of it. The other aspect is also about the actual disease itself. And again, just going back to this point of eminence-based medicine, classically, what we have seen is that people have held the view that if you're taking a certain medicine, or if you have a certain condition, that condition or that medicine in and of itself would disqualify you or would qualify you for fasting. And that's the sort of thing that we've been trying to get people to think again about.
Yeah, so there are exemptions from fasting during Ramadan, and seeking, I would think, advice from your religious authority in those circumstances would be worthwhile. So you can, as you say, have that informed decision about whether to fast or not, or whether there's an alternative to fasting that you can think about as well. So specifically then, what is it that patients worry about when they're taking medicines and they want to fast?
So usually it's usually a change in their condition. So most people that will be fasting will have fasted at some point prior to this, because typically people tend to develop illness in their later in life after they have been fasting for some point or another. It's not that common that you'll get someone that says, I've never fasted before, unless they're new to Islam or they've started practicing and they don't know how to go about it. So it's the prior experience element is a key thing to bear in mind. So it's a change in the condition usually, and that's either due to a physical change, so they've had a heart attack in the last 6 months, or they have got they've been told their diabetes is worsening, etc. Or there's a change in their circumstance. So they used to not work night shifts, now they're working night shifts, or they've had a baby, or they're looking after an elderly relative. And so that affects their ability and their tolerability of the fast, or they are traveling, or it is now the winter months, it's the summer months now. Their previous experience has been in the winter months where the days are shorter. It's a longer day now. I've got heat stress to think about. I've got dehydration to think about. So these are the things that are coming up. I mean, just the other day, I had someone speak to me. She's had a heart operation, a valvuloplasty a year ago, and she's now traveling this Ramadan to a hotter climate. And she's like, "Well, what does this mean? And what do I do?" And I should stress that these are the people that actually have not only the access but also the thought to speak to a health professional about this. There's a huge number of people that either can't access a health professional or they don't think they should, and those are the ones that I worry about far more.
Yes, I mean there's a potential health inequality here, isn't there? Because as you say, just like in any community, there are the kind of the people who are maybe more proactive about their health and those who aren't. And it tends to be the association is with areas of deprivation where people from areas of deprivation are less likely to seek help and guidance around their healthcare. So I can see a potential health inequality here where you have people who don't seek help and then are fasting and then don't take an essential medicine. Whereas if you've planned this in advance, I would think you can plan for this sort of thing as you just described. What did you do last time? What are your circumstances now? what were your previous experiences during fasting? You can then think about maybe risk stratifying. If you're talking to a pharmacist or another clinician about what sort of medicines you're on, whether you're on any risky medicines or whatever, and you can start planning for that. But if you haven't sought that advice and just think, well, I'm just not going to take my medicine, I can see a real issue there in terms of health inequalities.
I think it's also about not just the inequality in terms of experience, it's also the inequality in terms of outcome as well, or rather both, depending on how you choose to look at it. So you have got people that just refuse to engage with the system because they feel that the system doesn't understand that how important this month or this process is for me. So I'm just going to do it myself. I've honestly spoken to someone who's on insulin for their diabetes, who's just said, yeah, I've just stopped it, right? Because, I'm not eating as much. And you laugh, but these are the sorts of things that that's the length that people feel like they've had to go to because they don't feel like they can have that conversation with anyone in the system. And then yes, you have got those people that want to speak to someone about it, but either they don't know how to bring it up, or they brought it up and they're dismissed, or the clinician that they're speaking to doesn't quite know what to do. Hence the reason for us undertaking this work.
Yeah, so with that in mind, then, what guidance is there out there, either for patients or for clinicians, to help give sound evidence-based advice on what to do here?
Firstly, just to clarify, we're talking about those people who are on who have established long-term conditions. So there's a difference between someone who is acutely ill, as we were talking about earlier, versus someone who has a long-term condition. Because the religious authorities would strongly advise someone who is acutely ill to terminate the fast. In fact, there are certain conditions which would exempt someone from fasting, and being acutely ill is one of them. Being frail and elderly is another. Traveling is another. There are many other conditions for being a child is another one as well. We don't expect children to fast. Um, so to make it clear that we are talking about people who have got long-term conditions. So when it comes to looking at long-term conditions, what the work that we did when we put together the guidance through BEMA, which was looking at this beyond just diabetes, was to try and understand what is it that patients want, what is it that clinicians want, and trying to put the two together. And as we said earlier, patients have got an incredibly strong desire to fast. They're looking for any reason to undertake the ritual of fasting because they feel that gives them closeness to their community, closeness to God. It's what they want to do. And clinicians, on the other hand, are thinking, I don't know what to do here. How am I not going to get in trouble? How am I also not going to mess up this relationship with this person? Because, as we talked about earlier, again, in many cases, not all, but in many cases, these patients are presenting to healthcare for the first time in a very long time. And we've got a lot of things that we want to get out with them. So the framework that we developed at BEMA was actually taking on the work that the International Diabetes Federation had in place. They had established something called the Diabetes and Ramadan Alliance. And the Diabetes and Ramadan Alliance had essentially said that the way to go about managing patients with diabetes is that there needs to be a strong emphasis on risk stratification. And I think from one of the key things I'd like listeners to take away from this is that has to be the language that we use with patients, that we have to start using a more dispassionate but a very clear framing of the problem so that they walk away knowing in very certain in terms and with no ambiguity about what happened in that consultation that I've had. So what the International Diabetes Federation and the Diabetes and Ramadan Alliance did is that they had a traffic light system, which we're all very familiar with in many other parts of healthcare that we use that. So that red, amber, green traffic light system there. What we did is that we built on that and we recognized that there's more than diabetes out there. So we applied that same we did an evidence synthesis of the data that we could see and noting that there's a significant limitation to primary data in many clinical scenarios, and also there is limited data around coexistence of different disease, although there is some, for instance, with diabetes and CKD, you don't necessarily have primary data around frailty, obstructive sleep apnea, CKD, ischemic heart disease, um, which we can see, for instance, and the whole metabolic syndrome. Sometimes we haven't got those RCT level data on those types of patients. Nonetheless, we did what we could. Alongside that, we had, as I mentioned, 120 clinical experts trying to put together some sort of consensus, and we created tables based on evidence, putting various different conditions into that red, amber, and green traffic light system. But on top of that, what we sort of try to relay is an understanding of the conservative approach to applying the risk, because in the red, amber, green system, green typically is like it's fine. There's no risk. It's okay to proceed. But in our framing, we've actually called that low to moderate risk, because we recognize that there is a strong desire of people to fast, and we need to work with that. We need to recognize that people will be wanting to fast, and they need to be told to watch out for certain things that they wouldn't necessarily be watching out for. Likewise, in that same risk stratification, we actually have two categories whereby people should be advised that they should take caution with their fasting. So in the amber category, we've actually said that the advice is that you should not fast. Now, to the lay person, should not fast means that, well, that's a no, right? Well, actually, it's recognizing that there are going to be people that, despite their clinician saying to them that you should not fast, people will say, well, sorry, I've fasted for the last 40 years with this condition. Who are you to tell me all of a sudden that I shouldn't be fasting? So it gives the clinician a little bit more flexibility in order to say, okay, well, I recognize your previous experience. The evidence here is suggesting this. Let's see if we can come to some sort of shared decision, some sort of sick day rules that we can go through to try and understand things a bit better. Then there's the red category where the clinical guidance is that you must not fast. So it's a much more clearer advice from a clinical point of view that this is now heading into danger territory. It's no longer just something that you could probably get away with if you've got a good handle on your condition. Nonetheless, even in the red category, there will be some patients that will say, well, I've managed to fast with this condition for in the past, or I'm willing to undertake the risk and fast with that. Again, you would either apply the same sort of approach that you have with the amber category, but depending on the clinician's confidence and experience with managing that condition, they may not actually be able to offer any advice in that sort of situation. They say, well, are you doing so against your risk? You've got the autonomy. I can't see any reason why you should be, you do it at your own risk, but I'm not going to go any further than that. But a more experienced clinician might say, okay, if you're going to do that, then maybe we could do something else about that to help you get there. So that's essentially the framework that we've got there. And again, it's for long-term conditions. And we found it is very helpful because people walk away with that from that consultation, and they should walk away from that knowing one thing very clearly as to what risk did the clinician assign to me when I said, can I fast with my diabetes? Well, they told me that I'm at high risk and therefore I should not fast. And that's something that they can walk away, they can tell their family, they can tell their religious authority, they can tell themselves when they're doubting whether they are fasting or not. Because in the past we were finding that people were just not sure about what is it that the clinician said to me when I spoke to them. They're sort of umming and ahhing and saying you're taking this drug or you're taking that drug, or they're talking about the length of the day and the hydration and everything. Whereas now you've got a very clear risk that you're giving to people, and we find that works quite well.
Yeah, I really like that. I mean, essentially, this is the basic tenets of, or fundamental tenets of shared decision making and informed decision making. What you do is you explain the risks and benefits to people. You take into account their values and preferences, finding out what matters to them the most, and you tailor your consultation accordingly, as a good clinician would. There are going to be some categories where you can reassure and say, actually, I've looked at your medication regimen. According to the traffic light system, you're in the green box here, moderate, low risk. We don't think there's anything to worry about. You might do some safety netting and say, right, if there's any red flags that appear as a result of this, then please come back to us or adjust it accordingly. Then you've got the red category where it's clear, you're exempt from fasting here because there is a real risk to your health, a material risk to your health if you adjust your medication regimen during fasting. And then there's the bit in the middle where our advice is that you should not fast, but it's your decision at the end of the day. And here are the risks, here are the benefits, your decision. And it's actually very similar to the frameworks we use when we're doing shared decision making, Salman, isn't it? Very much. And I guess the other thing that jumped out at me was that relationship element as well with your clinician and how you manage that relationship. Because it might be that you've strived for years to get a good working relationship with a patient. If you then give poor advice or advice that, well, it isn't in tune with what matters to them, then you run the risk of ruining that relationship that you've spent years trying to develop and nurture. So yeah, there's lots of aspects to this as well. And I can see why this is of such an interest to you from a research point of view, because as you said, you're not going to get a large randomized controlled trial of 1,000 people where you compare people who fast with people who don't and see what happens. And you're just not going to get that level of evidence. So the pragmatic approach that you guys have taken here is let's have a look at the best available evidence that we have. Then let's get then let's get some experts in the room together, see if we can get some agreement and a consensus here, and then do a categorization of medicines according to risk with a framework for decision making. I think that's really, really well done there, Salman. Just the sort of thing that you'd expect when I used to work at NICE. That would have been the approach that NICE would take if they were asked this problem. And I think that's really helpful.
One of the things is around alternatives to fasting, because people talk about that and it's a bit unclear as to what that means. So if you are someone who is not able to fast for any particular reason because of an acute illness or because of a flare in your long-term condition or because you're traveling and so on, when we talk about alternatives to fasting, it's essentially saying that the choice of fasting isn't a binary choice of fasting all 30 days of the month consecutively. There are other things that you can do. So that could mean that you try fasting 1 day, 2 days, 3 days, alternate days, once a week, whatever your body can tolerate. It could mean that you try fasting after Ramadan has finished. It wouldn't be a Ramadan fast, but it would be making up for the fast in lieu of it, particularly in the case where your illness has prevented you from fasting in the 30 days of Ramadan. Or it could be a fast that you do much later in the year, in the shortest days of the month, if that isn't the time of the fast already, because that is usually a shorter fast, A, but also B, the climate is more convenient and conducive to people to fast. And then the final thing that can be done, and this is where people often do seek religious advice about, is that if you have a health condition whereby it is going to be impossible for you to fast, you then pay charity in lieu of you fasting. So you pay charity to someone else to be fed, and that is your contribution to Ramadan, as it were. That's your fast, quote unquote. I mean, you're not fasting, of course, but you're enabling other people to be fed. And so that's what people do when they have got serious long-term conditions, is they pay that. But they still take part in Ramadan's other rituals, such as the prayer, such as the communal activities, etc.
So just to finish off, just in terms of what are the three things that you think clinicians or patients should take away from our conversation here?
We didn't really touch on it, but I think one of the things is to recognize that Ramadan is for many Muslims who observe it, that moment of reset. It's a bit like, and it's a global phenomenon. So whether you're in Timbuktu or you're in Thailand or you're in Teesside, if you're a Muslim observing Ramadan, it's a bit like your New Year resolution, right? That this is a new opportunity for me to be a better version of myself. And there's an opportunity for us working in healthcare, and this is more of a public health angle, I guess, but to just see what we can do to tie into that and tap into that. Now, community pharmacists in particular, I think we've got a real big role to play here in terms of what can we do, given the huge amount of, the huge potential, especially with the inverse care relationship there with pharmacists being located in places where significant inequity exists. what can we do to tap into that Ramadan experience and that idea that people are resetting their health to make more meaningful conversations around their health? So whether it's smoking cessation being a classic example, where smoking would invalidate the fast, so people are not smoking. Muslims who are observing Ramadan will not be smoking during daylight hours. Isn't that a brilliant time for us to be thinking about transdermal nicotine preparations as NRT for these communities? So there is, I think, a huge, potential for us to tap into around thinking and entering into that mindset of what these communities are going through and trying to match those rhythms. And the key thing here is not to try and force that behavior change to happen in Ramadan itself, because there's other things going on in people's minds, but it's to plant the seed and to just gently nudge them such that either prior to Ramadan, so look, Ramadan's coming up, why don't you get yourself, match fit, get yourself ready for Ramadan, especially as we head into the winter months, and coughs and colds and influenza and COVID and all these things are going to be uh, more and more aligned with the Ramadan season. There's opportunities here for us to think about how do we engage with our public health work there. So I think that's the first thing that I would encourage people to think about. What more could you do pre-Ramadan and post-Ramadan to do that? Linked to that, I would say, is that we're all stretched. We're all, operating above our capacity, and it's unrealistic to expect services that are stretched to offer additional capacity for something like this, because this is one of many things that are going to be knocking on people's in trays about, can you do more for these patients? So instead, I would say that in the routine reviews and the routine conversations that you have with patients, especially leading into Ramadan and also after Ramadan. So again, this could be in pharmacists working in general practice as part of the medication reviews. If you know your patient is observant and is practices the fast in Ramadan, just ask them. It can be pre-Ramadan, it can be post-Ramadan, it can be during Ramadan. It doesn't have to be a new conversation, a new consultation that you look to elicit, to ask them about the fast and their intention to fast. And what you may find is that you could actually bring in a cohort of patients that wouldn't traditionally have taken part in QOF, for example, or had their lipids checked or whatever it is, or had their blood pressure checked, because it hadn't been conveyed to them in a meaningful way. So if you say, look, let's check your blood pressure, let's get your spirometry done, let's get your whatever checked, let's get your smear test done, so that when you enter Ramadan, you're not thinking about your health, you can focus on the fast. So I think that's another thing that I'd encourage people to think about. And I think, again, pharmacists have a massive role to play here, especially when it comes to those regular interactions with patients and to gently nudge them towards making better and healthier choices. And the final thing I'll say, just to reiterate what we talked about earlier, which is about being able to convey risk clearly to patients. That has to be the key thing, that patients need to walk away from any encounter about Ramadan and health knowing, am I red, amber, or am I green? When I've spoken to religious authorities, and bear in mind, some people deem themselves to be a religious authoritative in religious matters enough that they decide whether they do and don't fast. It doesn't mean that every Muslim has to go to speak to a someone else about it. But those people that do speak to someone else, often when I speak to them about, so say I've said to, someone's been told that you've got X condition, you shouldn't fast. When you speak to the religious authority that they've spoken to, and they've said, actually, no, I spoke to my imam, my imam said I can fast. It's because they've actually told the imam the completely wrong thing. And they haven't actually understood what it is that you've said to them. And so the imam has understood a much more benign version of their illness and therefore given a much more permissive opinion. But if you say to the imam, look, imam, this person is at much, statistically, is at greater chance of harm than any benefit from fasting. My advice is that they shouldn't fast. It's almost unanimous that the religious authority aligns to the clinical opinion to say that, yes, my religious advice is that you shouldn't fast as well. But having that clarity is so important, and knowing that that clarity is not based upon any particular, there's no killer point. It's not like you're on an SGLT2, therefore you cannot fast. There are very, very, very few conditions, if any, where that is the case. There are many people who are, actually, and on the flip side, if you look at some guidance, it will say that if you're a type 1 diabetic and you've been fast and you've had diabetes for more than a certain amount of time, you're automatically in the higher risk category. But nowadays, with technology, with CGMs and, greater awareness that people have, and if you're fasting in a shorter time period, in a shorter climate, it is quite possible for you to fast. So just bearing in mind that those risk categories still need to be tailored to patient choice, as you very, very eloquently put there earlier, but they must be conveyed to the patient around apportioning that risk to people.
So, Salman, that's really helpful. I love those 3 points. So there's that opportunity, especially for community pharmacists. And my friend Adam Todd will be listening to this and going, fantastic. He's done lots of work on how community pharmacies book the inverse care law. We've had him on as a guest on the podcast, so that'll be music to his ears. And as that, also, it's a good time for a medication review, and actually potentially an opportunity to deprescribe here as well, if you do it in a thoughtful way, because it might well be that a person doesn't need the medicines during fasting. Actually, do they need the medicines at all? Is that going to be a choice for the person as well? And then I think that risk communication thing at the end, and that clarity where you've got increased agreement about so that medicine's green, that medicine's amber, that medicine's red, and you can convey that to the imam or the other religious authority, then that can only add clarification and potential sort of better decision making there as well. Because I as soon as you said that, sort of like a person telling the imam one thing but not telling them the whole story, whereas actually if their imam's got that guidance as well and says, well, actually that medicine's is a red medicine, you're exempt from fasting because of that, then that can be helpful as well. But as you say, there's no, it still requires that that shared decision making to be made to inform that.
As I said, it's often not so much the medicine that they're taking; it's more the condition that they've got and the state of their condition. There are instances, yes, if you're taking insulin in your diabetes and you've got diabetes, that yes is the medicine with that condition. But more often than not, it's the actual state of the condition and then the functional impact that the condition has on that person, or the recency of which a flare up of that condition has happened, that it actually apportions the risk. But again, I'd stress that this is as much as possible based on evidence that is published in the peer-reviewed literature, but it's not by any means comprehensive or complete. And to be clear as well, much like with contraception guidance that we have with UK MEC, there isn't a aggregation of risks. So in UK MEC, for example, if you've got two ones, that doesn't make a 2 or a 3, and likewise, 2 3s don't mean a 6 because that doesn't exist. The same thing in this risk stratification here. So you do need to exercise clinical judgment in all of these cases. Again, going back to your very well articulated point around this is the fundamental of this goes back to the fundamentals of high quality shared decision making with patients. It's just that I think the experience for Muslims who observe Ramadan has been that they found it difficult to access that quality of care that we come to expect in all of the conditions that we have, because Ramadan fasting has this sort of mystery or this sort of an unfamiliarity attached to it, which I think does make it difficult for clinicians, if I'm honest, to be able to provide that type of advice. But we hope now that with this becoming more mainstream and people having access to this type of information, these sorts of conversations will become much more commonplace. And we can move from talking around Ramadan as a barrier to health and more around what we talked about earlier around Ramadan as an opportunity for health. So we talked about smoking cessation very briefly. What about mental resilience? What about weight management? What about, social connection? All these other things that we know are so important to people's health and provide benefit to their health, which, in good time, I hope we'll be able to cover.
Fantastic. I love the analogy with UK MEC, actually, because you're absolutely right. You can't read it as a book and go, right, I'm going to and do it, use it as an algorithm for practice. It gives you information in order to make a better informed clinical decision, which is difficult. And you know what? Medicine is difficult. And otherwise everyone would be able to do it, wouldn't they, Salman? It's not. It requires judgment. It requires wisdom to be able to do that. Salman, that has been absolutely fascinating. Thank you so much for your time. We will put some links in the show notes to those resources that you mentioned. And yeah, thank you so much for coming and joining us on Talking Meds. Entries for the annual PrescQIPP Award 2026 are now open. The deadline to submit your entries is the 15th of May. This is open to all teams working within the NHS across all sectors. It's a real opportunity for you to share all the good work that you've done over the past year and being a chance to win a prestigious PrescQIPP award. Check the link in the show notes and get your submissions in now.